what I'm going to talk to you about is status epilepticus, but I just have to maybe warn you that I'm a pediatric neurologist, and some of the things that the adult neurologists are doing for status epilepticus might be slightly different from what I'm going to talk about. So let's move on. Okay, so to start off with the question, yeah, do I have to read this out, or you can read this? You want us to read it? Okay, so this is a 55-year-old man who is having a generalized tonic-clonic seizure. You are called to see this person. The only history available is from a casual acquaintance who had brought the patient in, that he was getting out of the trishaw to come to the neurology clinic. That's all that we know, and the patient has come with a seizure to the emergency department. Your initial assessment, so the first question is, your initial assessment of this patient would include the following: blood gas, optic fundal appearance of epiledema, abnormal posturing, detailed clinical history, all of above. I give a minute for the answers. You can come back. Okay. So the second question is, when you do start anti-seizure treatment? After 5 minutes, after intravenous cannulation, immediately, after 10 minutes, after consultation with the consultant on call. So that's the second question. So mind you, the first question was about how we are going to assess this patient. The second question is about when are we going to start treatment. Okay, so the third question is, he continues to have seizures 5 minutes after 2 doses of midazolam. What is your next step in the management? So now we are in trouble, 2 doses of medication given already midazolam, and the patient continues to have a seizure. So administer intravenous diazepam, assess blood glucose level, call for assistance, administer intravenous phenytoin, administer intravenous levetiracetam. Again, all the answers are like we are looking for the best and the most correct step to take at that particular time. So we are talking about the second line administration of medication. Okay, with the questions in mind, let's proceed to the talk. So if you look at status epilepticus, it's the most common neurological emergency with very high mortality and morbidity. So if you look at these figures and think of any condition such as what we are scared of, something like even dengue hemorrhagic fever, this is far more than what you would see with somebody who is having the most of the conditions that we are very scared or worried about. So look at the last bullet, the risk of epilepsy after status going up to 40% in some adult studies, mortality and morbidity both. So going back to, so it's very much worthwhile knowing, actually learning what to do, exactly what is the best thing to do in a situation of status epilepticus. So what is status epilepticus? The definition says a seizure that persists for a sufficient length of time or is repeated frequently enough that recovery between attacks does not occur. Right? So we all know this definition. Maybe the only difference is that we have this word sufficient length of time. So what's this? So there is no particular time given in this definition. It says sufficient length of time. What do you mean when you talk about a sufficient length of time? Okay, so then we come to another concept where we introduce this concept of T1 and T2, time 1 and time 2. So time 1, to keep talk about in simple language, is the time beyond which you are not expecting the seizure to stop by itself. And time 2 is where you know that the neuronal damage, or in simple language, brain damage is going to happen. Right? So now, interestingly, when you talk about T1, people who have seizures have 2 particular mechanisms working in their brain. One mechanism is a mechanism to stop the seizure. Right? So at T1, we think that there is a failure of mechanisms responsible for self-termination of seizures, as well as there are other mechanisms which lead to abnormally prolonged seizures. So these mechanisms also get activated. So there are two sets of mechanisms which are actually promoting the seizure to be prolonged by the time you are at 5 minutes, or some of the studies say 6 minutes. Right? So this has been like repeatedly corroborated in many, mostly animal studies as well. So after T2, we know that there is neuronal death and neuronal injury. So what are these two times that we are talking about? Okay, so if you look at this, if you are talking about a tonic-clonic seizure, generalized tonic-clonic seizure, the T1 at the time that we are not hoping beyond this that the seizure is going to stop, that's 5 minutes. And the time where we are expecting brain damage is by about 30 minutes. So if you are not thinking that the seizure is going to stop beyond 5 minutes, obviously we have to start treatment at that point, right? And if we know that brain damage is going to kick in at 30 minutes, obviously we have to stop the seizure proceeding beyond, right? For focal status epilepticus and absence status epilepticus, these times are slightly different, but the data is not of good quality at all of those timings. And even for the tonic-clonic status epilepticus, we don't have like a class 1 or whatever data, but for the when you move down, this data becomes even more iffy. So just one more concept that I just want to talk to you about before we proceed further. This is called receptor trafficking, which is very important in seizure management. So we have two sets of receptors that we talked about when we are talking about seizures, the GABA receptors and the NMDA receptors. The GABA receptors, when we activate the GABA receptors, what we call the seizure activity will reduce. And those are the receptors that we are targeting when we give the benzodiazepines, which all of you know is the first line treatment for status epilepticus. So what happens with time is that the GABA receptors get internalized and they are no longer available for the drug to act on. And again, the drugs can't go inside the cell and act. They act on the cell membrane receptors. So once the receptors are lost to them, the drug has no way of acting. NMDA receptors, on the other hand, they come out on the surface. So that's drugs that act on the NMDA receptors are going to be better and better for usage as time goes along. Okay, so now back to managing status epilepticus. We have a problem. We have a patient whom you know has a condition that's going to cause neuronal damage and quite a possibility of dying as well. But on the other hand, we have medications that are used that again have a lot of like a bad side effect profile, and occasionally, if not carefully handled, can even cause death again. Some more things to complicate matters. So the complications of status epilepticus, not just having the seizure, but other secondary complications, they also can give you morbidity and mortality. Very simply putting, even an aspiration that even can cause your patient to die. That doesn't stop there. Etiology. So your etiology of your status epilepticus could be a meningitis following which you might be left with a hearing deficit, or maybe a large ICH. If you don't evacuate, your patient is going to die. So multiple things that you have to think about. So how are we going to balance all these things together? So what we do is we keep all those factors in mind and look at them simultaneously and continuously. So that's an important word to remember, that these assessments that we do, they don't stop. You don't look at your ARA breathing circulation, start your seizure treatment and forget about that. So you continue to assess your ARA breathing circulation, treat the seizure at the proper time, 5 minutes for generalized chronic seizure, we already learned that. And etiology may need urgent treatment, and some of these patients may need what we call the neuroprotective measures, which I'm not going to further talk about, but I think probably all of you all know. Okay, so when you talk about ABCD, anything particular that we have to look at in a patient with status epilepticus or having a seizure, ARV, of course, we have an unconscious patient. ARV always has to be protected, but this patient is with a seizure is likely to have excess secretions as well. Breathing, adequacy and pattern can give us adequacy, of course, we have to look at. The pattern can give you clues to your etiology. You might be dealing with a patient who is having a what you call a hindstrokes breathing due to a brainstem herniation or pathology. So that's just an example. Circulation, again, we have to, of course, look at adequacy, basic ABC. Hypertension can give you etiology, proof for etiology. You might be dealing with a hypertensive encephalopathy or maybe part of your Cushing's triad. Bradycardia, again, could be a part of your Cushing's triad. And moving from there, so when you are looking at what we call D or disability, so I have combined that with the second part, that is etiology, because the assessment of the disability and assessment for the etiology usually go hand in hand. So just to make things easier, we can classify the etiology into known and unknown. Unknown is, of course, unknown, right? So if you have a known pathologist that we might be able to elicit, maybe acute symptomatic conditions such as meningitis or encephalitis, hypoglycemia, vascular events, intoxications, and you can add a lot more to this list. We might be thinking, just to make things easy for us, we might be thinking of remote pathologies, post-traumatic, post-encephalic, etc., or even progressive cerebral condition. So look at the first category, the status epilepticus in defined electroclinical syndromes. Somebody has epilepsy, we already have a non-electroclinical syndrome, and you might be having status epilepticus associated with that. And this time, this might even be their presenting, it might be the first time that they are presenting with the status epilepticus itself even. So when you are looking at etiology and disability, we will be looking for clues of all these things. So again, just to highlight, when you're looking at known, that's another thing that we have to look at patients who have been on antiepileptics. So multiple reasons could be poor compliance, maybe the dose is too low, especially comes into play in pediatrics because the patient's body weight keeps changing, or there may be even lifestyle changes that has caused the antiepileptic, the usually well-controlled seizure to go out of control. Okay, so some of the basic assessments that we'll be doing, glucose, it's a must. And in fact, when we are doing APLS, we talk about APLS with pediatric life support. We talk about airway, breathing, circulation, ABC, DEFG, which stands for don't ever forget glucose, right? Pupils, a lot of information, right? You might be getting some clues about etiology, toxins ingestion can give you small pupils, large pupils, and again about impending or already happened then stem dysfunction or herniation. Posturing very important. Sometimes you might forget to look at that. Again, gives you a good clue of raised intracranial pressure. Neurological deficits, fever, meningism. I think the rest of it is very self-explanatory. Remember the last one as well. It might be giving you the answer. Okay, so we have looked at ABCD, etiology, ABCD and etiology. Now let's get to the treatment of the seizures themselves, right? And mind you, if you have multiple people involved, it's always, you can do all these things together even, and you have time gap between 0 to 5 minutes because we are going to start treatment at 5 minutes. If your patient is in that gap, you have 5 minutes is like a long duration actually for stabilization and to assess your critical life-threatening etiologies, which might have to be managed even before you manage your seizure. Right? So this part again, I think we all know about it. So you stabilize ABCD. You try to assess the time from seizure onset because it's again crucial. You don't want to go in too early and treat the patients with nasty medications. Initiate ECG monitoring. Check for capillary blood sugar, and if you detect hypoglycemia in pediatrics, we would be giving dextrose. In adult patients, because alcoholism is common, we'll be giving dextrose in combination with thiamine. So attempt intravenous access and send off the basic blood screenings that could be etiologically helpful for you to manage your seizure. Prepare the first antiepileptic drug. So that's a very important statement. So 0 to 5 minutes, you are not going to wait for 5 minutes and then look for your diazepam or midazolam. In your experience, how long is that going to take for you to find the drug and like get your dose out and do all that? Probably another at least 5 minutes. Right? So you are going to prepare your medication while you are waiting. Simultaneously plan early initiation of neuroprotective strategies. Intubation and neuroprotective ventilation may even be necessary at this point, even before we think of giving the treatment. So if there are multiple people, we can do all this simultaneously. Otherwise, we go A, B, C, D, and decision treatment. Okay. So once a patient is stabilized, you hope, like, and if the patient is lucky and depending on the etiologist, he should have stopped. If it doesn't, then you go for standard treatment. If it doesn't stop, you go on to benzodiazepines. And remember, your receptors are going to get internalized, so you go in as quickly as possible. You go in at 5 minutes. So you give one dose, you wait for 5 minutes. After giving that dose, no response, you are going to give the second. Patient continues to have the seizure, so you are going to give the second dose of benzodiazepine. So this is the time that we call the time of initiation of treatment. Right? So again, we have diazepam and midazolam available to us. Lorazepam, clonazepam, the other medications may not be available to us. If we don't have IV access, we can use buccal midazolam or rectal diazepam, or sorry, I'll go on to the other one. You can use midazolam intramuscular, intranasal, or buccal, or you can use diazepam rectal. Right? But some of the things that we might not be using so commonly, I don't know about the adult practice, but in pediatric practice, we may not be using it all that commonly, is intramuscular midazolam and intranasal midazolam, shown to be non-inferior to giving intravenous lorazepam, which is often taken as the drug of choice for treating status epilepticus. And in fact, in a patient who at 5 minutes does not have intravenous access, there are studies to show that intramuscular midazolam or intranasal midazolam would actually be superior to giving intravenous medication, because you are going to take another minute or two to put your cannula in, and your benzodiazepine receptors, they are vanishing receptors, they will go in, right? So you don't have to worry about non-availability of lorazepam, clonazepam, diazepam, midazolam is good enough. And the risk of side effect is the same. Again, another mistake we do is we think that if we give rectal diazepam versus intravenous diazepam, we are going to escape without respiratory depression. But probably what's more likely to happen is that your dog may not be absorbed that well. You are going to have to give a second dose, and you're probably going to risk another, have a higher risk of respiratory depression rather than not. Right? Okay, so you have given two doses of benzodiazepine. Your patient is still fitting. What happens then? Then we have to move on to what we call second line therapy. Right? So second line therapy, again, so once you have given your 2 doses of benzodiazepine, you are not going to like twiddle your thumbs and wait and to see whether your benzodiazepine is going to work. So that is the time that you again utilize to prepare the next line medication, because as you all know, drawing up a medication, preparing it, giving it intravenously takes time. Right? Okay, so we have few choices: levetiracetam, phenytoin, valproate, lacosamide, all given intravenous phenobarbital. Right? So if we look at these medications, again, the world is sort of moving towards giving levetiracetam, but if you look at this data, you can see that when you look at the first one is actually 2 pediatric RCTs, which compare intravenous levetiracetam versus intravenous phenytoin, and these 2 studies are showing that there is non-inferiority of phenytoin when you compare with levetiracetam. So as you all know, what's good about levetiracetam is the side effect profile. Right? You know that phenytoin can cause cardiac side effects. Phenobarbital can cause respiratory depression. Levetiracetam you can give without worrying that much, and you can give it a little bit faster than the other 2 medications. So again, I don't know whether I had it over there. So yeah, so the timing is also there. So you are probably going to take 20 minutes to do phenytoin and phenobarbital. Levetiracetam, 15 minutes or even 10 minutes you can administer the medication. Right? So look at the meta-analysis in the second square. Effectiveness of second-line second-line therapy for status epilepticus. So phenobarbital comes on top. So as you know, at higher doses can be even used as an anesthetic agent, followed by valproate, lacosamide, levetiracetam, and phenytoin comes out last in the competition. Right? So there was a time that people were saying phenytoin is the superior medication, but now the new data is actually showing us it might not actually be so. Okay, just a word about phenytoin, a very good medication because it's readily available, but you have to be cautious because there are patients, your patient can die of phenytoin. Unlike respiratory depression, where intubation and management is like easier, if you get a cardiac arrhythmia or dysrhythmia, you might be in more trouble. So there is a maximum infusion rate and even a dilution. Avoid dilution in glucose solution as it precipitates and you might be giving intermittent boluses or giving an inadequate dose. Infuse via separate venous access. Large venous cannulas are usually preferable because high risk of thrombophlebitis as well. Obviously, heart rate and pressure must be monitored because the two side effects are cardiac arrhythmias and hypotension. Contraindication, if you already have a risk of, if you already have a arrhythmia or a high risk of arrhythmia or severe hypertension. And of course, avoiding patients already on oral phenytoin, as you know, the therapeutic index or the therapeutic window is quite narrow. Okay. So we have stabilized our patient, 2 doses of benzodiazepine given, nothing happens, we have given the second line therapy, right? So what comes, what are we going to happen now? So now we come to what we call our weak point, right? So the world over, this is the first weak point that people have sort of identified the world over is the reluctant or the not starting the first benzodiazepine dose at the correct time, or giving inadequate doses in non-intravenous methods other than the intramuscular or intranasal midazolam. The second weak point is the reluctance to move over to the anesthetic agents. So all of us who are practicing, looking after patients who have seizures, should be able to look after the airway of a patient, intubate and take over the airway of a patient. Or if you are unable to, when your second line therapy is going, this is the time to call for assistance to take over the airway. So it's a must thing that you have to get the patient into a place where the airway can be taken over, and you will be moving on to give an anesthetic agent. Again, I'm not going to talk very much about these agents. So we have a choice of agents. We can be giving everything carpenton, or you can even use phenobarbital there. Again, just a word about ketamine. If you are very, sorry, so to start off with midazolam, you might be even able to go up to levels of 5 or 6 micrograms per kg per minute without taking over the airways. So might be a medication that you can use. Thiopentone most often will have to take over the airway. Ketamine, again, you might be able to go up to the 40 milligrams per kg dose without taking over the airway sometimes. So if you have a problem there, that's something that you can do. And if you have a real problem, you just cannot take over the patient's airway, and there is nobody available to do that, right? So are we going to give just going back there, therapy and wait? You do have a place if you really can't get at somebody, or you are really not confident that you can take over the patient's airway, you might be able to try a second dose of a second line therapy. And some of actually the pediatric protocols that are coming out, especially the Canadian protocols and some of the US protocols, are actually giving it as part of a protocol that before you go on to the anesthetic agent, you try a second dose of second line therapy. Okay. So other agents, when the patient is becoming very refractory, we have an array of things that we can use. Again, just to stress on the immunotherapy, sometimes you might even start it very early because some of the status epilepticus, especially in the young patients, could be immunologically mediated with, as you know, about autoimmune encephalitis, loss and virus. All these are conditions that will present with status epilepticus. Okay, I'm not going to talk about very much about that. Just a word about EEG monitoring. So according to protocol, all patients who do not make a good immediate recovery following status epilepticus should be undergoing EEG monitoring. So multiple users, if you are on anesthetic agent, that will give you, you might be aiming for burst suppression, which you can only see on your EEG. Not essential, but you might be, if you are aiming for that, you might only be seeing it on the EEG. You might be seeing electrical seizures going on for a long time, which you might have to treat. And most importantly, even more than that, you might be seeing non-convulsive status, which is something. Now, the electrical seizures, you have choice of treating or not treating. Non-convulsive status, usually you would have to treat, and your patient is not going to recover unless you treat with that. Okay, so I think probably that's what all that we have to be talking about in status. I'll be talking to you about in status epilepticus. Just to summarize, ABCD treatment of the seizures, looking at the etiology and neuroprotection are simultaneous and continuous processes that have to go on together and all along the assessment. So we talked about T1 and T2. T1, yeah, we know this seizure is not going to stop. We have to start treatment. T2, we have to stop the seizure before that because we are risking neuronal damage if the seizure goes beyond. Okay, so back to the questions.
When you put the question, there will be going on.
Is that going to happen? Okay.
So on the participants can answer.
Okay.
Yeah. You also can respond physically. For the first
The question right allow them to answer
How long? 2 minutes, 1 minute, 2 minutes, 1 minute. Yeah. 30 seconds. Okay. Yeah.
Yeah, it's already started.
Already started. Okay.
Share the results for the first one.
So
Yeah, you can try to answer while the others are polling. They don't have they can't poll. No?
so they can,
Okay. Yeah. Okay.
so initial assessment will include the following. It says blood gas. Answer.
So we are talking about this particular patient, right? Okay.
Under appearance of ability. Answer. And then is abnormal posturing. Detailed clinical history. All of the
There are a few answers for that. Doesn't look like anybody wants to assess this patient, right? Right.
about four.
Okay.
Yeah, this is
So all of above. Okay. So probably now I think 82% have said all of above. So I would agree with you in a way that we might need to do all of above at some point, right? But now, mind you, we are talking about a patient who has fallen out of a trishaw, having a seizure, right? Somebody has brought to the OPD, outpatients or emergency treatment. How long do you think that would have taken? You don't immediately, not like your relative has fallen, right? People gather around you, you'll be talking about it, and one person would decide, oh no, okay, we are going to take you, find a trolley, put the patient on the trolley, and then you are going to come to the emergency treatment department. Right? So the patient has come, probably have taken some time. You don't have much time. So at this point in the initial assessment, we do only the very essential thing. Mind the word, your initial assessment, right? Not your assessment. So if you are looking at all these things, out of this blood gas, probably not going to be part of your initial assessment. You are going to clinically assess whether there's adequacy of your circulation and respiration, right? So optic fundal appearance of epilepsy very good if you can do. Who has tried to look at the optic fundus in somebody who has having generalized tonic-clonic seizures? Hands up. Anybody who has managed to see the optic fundus? Okay, right? So we don't waste time doing things we know that we can't do. Right? Abnormal posturing. Again, like we talked about in the talk, something that we tend to forget, but would give you a very obvious something that you can see a feature of raised intracranial pressure. In fact, critical raised intracranial pressure. So something that you should not forget is to look for posturing. Detailed clinical history, are we going to be, so mind the word detailed, right? Are you going to, this is not the exam, right? You are not going to sit and get the only time that we get a detailed clinical history is at the exam, or probably when you are stuck with the patient, right? So this is not the time to get a detailed clinical history. So obviously all of above is going to be incorrect. So all of above will be done sometime, but at this point, probably only thing you will have the luxury of looking at would be the abnormal posturing, right? And again, mind the word, not that we don't want to do all of this, but we have luxury of only looking at the third question, third answer. So can we go on to the next one? Next question. I have to go down. No, sorry.
next one, when will we start anti-seizure treatment? After 5 minutes, after intravenous cannulated vision, I can't see. Yeah.
Okay, the question is, after 5 minutes, after intravenous cannulation, immediately after 10 minutes, after consultation with the consultant on call.
We'll start from Zoom link. How about the first one? Hands up those who say the first one. Second one after IV cannulation. Immediately. Majority after 10 minutes. One after consultation with the consultant on call.
How do you think? So what does the call say? After 5 minutes and after immediately 50-50 divided. Right? So I think probably that's okay, right? In the way, so if you take this clinical scenario in your own mind, you're probably 5 minutes already gone. So probably the correct answer here would be immediately when you think about when you are seeing the patient. But it's just a matter of terminology. So if you think of the timing of seizure onset, would have been at the time that the patient fell. So you think at after 5 minutes. So we'll probably accept those answers.
Question number 3 now, the last one.
Yeah, last question. Okay.
So third one, he continues to have seizures findings after 2 doses of Insulet. What is your next step in the management? Number one, at least IV diazepam. Second one, assess blood glucose
Third form call for assistance.
Fourth, administer IV Phenytoin. The final one, administer IV Levetiracetam. Four starts now. The first one, the first one. Administer IV diazepam. One, assess blood glucose level. One or two coming up, yes. All for assistance. Few, right? At least I very time. Very few. Administer IV Levetiracetam. In few, majority is nowhere. What?
Yeah. Okay.
Yeah.
Yeah.
For diazepam, arterial blood glucose level 26%. IV Phenytoin majority 38%, and IV Levetiracetam 32%. So majority is for the fourth and fifth.
Yeah. So I think probably that's good. The majority got the message that what we are going to now come into the what we call the second phase of the treatment or the second line treatment. Again, calling for assistance is good at any time, but that's not the best thing to do in the sense. So we are looking for the best answer, whether there is assistance or not. At this time, we have to go to the second line therapy, right? And nobody said administer IV diazepam, I think, right? So we have all got that message. Assess blood glucose levels. You had said that, but probably what the message that we are trying to discuss about at this point is this should have been done way earlier than at this point, right? So if you had a doubt or if there was like almost low blood sugar, you would still have administered glucose. So you probably not doing that. So what's the toss up? The toss up is between Phenytoin and Levetiracetam. So again, maybe I will ask the patients people who are here. Now you have to take one, right? Because I can see all of you. Who would give Levetiracetam? Who would give Phenytoin? Who would give Phenytoin? Okay, one person, two people. Who would give Levetiracetam? Majority, yeah. So what's the reason that, like, maybe why are we thinking Levetiracetam is better than Phenytoin at this point? Any answers for that? Why did you vote for Levetiracetam rather than Phenytoin?
Yes, that's fine.
Yeah, you had some reason. So what's the reason?
That's a discussion. So, I mean, there's no yes or no answer.
Yeah. So why are we going to like again we said we have got the main message now. We are going to give the second line medication, Levetiracetam or Phenytoin. So now we have to choose the medication. How are we going to go about that? Why are the people who said Levetiracetam, why did you choose that? Sorry? Yeah, okay. So Very good. Infusion time is less. You might be getting, and we don't know that we probably might have been delayed in starting our first dose of benzodiazepine. Also, we don't actually know what the time of onset of seizures was. Any other reasons? Read the question again and see. You might be getting some more answers. Don't forget your patient.
Past medical history,
We don't know the past medical history. Yeah. And the thing what we know about in the past medical history is that patient was coming to the neurology clinic, right? So patient could have been having seizures. And if in fact we substitute that with neurosurgical clinic, patient would have most likely being on phenytoin as well, right? So you might be having trouble there. So that's one of the reasons that you might be choosing levetiracetam. We can't say phenytoin is wrong, but again, when you are using phenytoin, one of the things we say is if you don't know the past clinical history, unless we don't have an option, better not to use phenytoin. Okay.
Oh,
Right.
yes, excellent. Pyara, thank you very much for your.
Any questions?
Yeah. So just 1 second, Darshana. Can I just say, I think probably if you go back to the first question, right? I think probably we find it a little difficult to answer that question. I think probably actually that's one of the most difficult parts in management of the status epilepticus. But you have to always remember there are so many things that we have to do. We have to treat the seizure, we have to get the cannula in, we have to look at the airways breathing circle, we have to assess the patient. So when you are assessing the patient, we are only going to look at things, 2 things. One thing is you are going to assess and look for things that's going to kill your patient. Second thing, you are going to look for an etiology that needs treatment other than anti-epileptics. So if you remember those 2 things, I think the assessment becomes easier.
There's a question came up in the chat box. IV levetiracetam, is it available in Sri Lanka?
Yes, it is available. Yeah, it's available.
The issue is nothing is easy at this moment, so
Yeah.
it's available, but not very freely in the government sector. That is the issue. It's available.
And just to add another thing to that, I think right now we are having a shortage of intravenous phenytoin as well.
Yes.
So I think the message there would be don't sort of worry to use phenobarbital. Good drug, right? So if you have a problem in the airway, you can like get some assistance there. Use phenobarbital.
I think actually if we have 2 minutes, this is an area where there's room for discussion, because if you really go through all those trials, all 5 medications, there is not one which says one is superior to the other, right? So we have 5 IV medications which can be used, and in fact, if you take that recent trial, they're all the same. Here there are deciding factors. It seems to be the other factors which makes you choose the medication, right? So therefore, like for example, the other comorbidities or unknown history or the less adverse effects, because they are going to count to all the things that we discussed, because comorbidity related to the medication, right? That's also something that we have to counteract, and the ease of administration. But on the other hand, is the cost, right? So don't go over with the message that IV levetiracetam is the answer. Definitely no, it's not better than the others. Efficacy wise, they are all the same, but the choice is sometimes determined by other factors. Right?
Kishan, just want to add to that. The timing. How
Yeah.
quickly you initiate your treatment, that saves the patient's life. That's the most important message out of all of it.
This is about the trafficking, the receptor trafficking. So if you use the correct one at the beginning, you will not need to go to the second level.
Yes, is correct. So I'm just wondering, because nowadays, IM is a just come to line like from quite recently. So you have the luxury of doing IM up to on EASL. What would you prefer? Because most of the medical students, during their IVAs and long cases, would jump and say that it's IM.
So
What is
again,
do we have enough evidence to say, or?
yeah. So again, I think probably the evidence says that if you have a cannula in already,
We don't have any.
so at 5 minutes, if you don't have a cannula in, right? So the intramuscular or intranasal, not buccal. Intramuscular or intranasal midazolam has shown superiority over lorazepam given intravenous. And unfortunately, the intravenous midazolam, it's not the intravenous midazolam we are talking about. Intramuscular or intranasal midazolam versus intravenous diazepam.
Okay, we can answer number one, lorazepam because we don't have, right? So that what you say is correct,
Yeah.
but then we don't have lorazepam.
Yeah.
Second one is we don't have intranasal or sexual buccal preparations.
Yeah.
So what we are going to use is the IV preparation. So intranasal, the problem is to give that volume into the
Very
nose
difficult.
becomes difficult because in the child, particularly, the amount that you can infuse into the nose is little. Because of that, right, we have to use the buccal or the IM. The clear message that you have to take from what Dr. Pyara said was this study which showed there is no difference in the outcome between these benzodiazepines, right? Even when it comes to respiratory depression, that is what you have to remember. The important thing is if there is no IV cannula, the time taken to administration is the one which shortens how quickly you achieve your seizure control. So if no cannula, you can use IM or buccal or intranasal. The problem with the intranasal is the same preparation, you can't put so much into the nose because this is small. Right? So we have left with two passages.
Yes. So, and out of this, what we say is that intramuscular would be better. We have the data is for the intramuscular, but if you have the cannula in, because like Jithangi was just saying, we don't have a difference between the side effect profile, whether we give it, whatever the route we give. So if you have a cannula in, the intravenous route is the best route. Does that answer your question or not?
Well, yes,
So what's the no part?
right, because it will take some time for it to get absorbed if we have a clinic intramuscularly.
Yeah, but
I don't think
yeah.
that we have enough studies, critical studies between intramuscular, intranasal, and
So that's the same thing. If you have intravenous access,
Yeah.
you don't give other.
Oh, that's
If you don't have, what it has been shown is the time taken for intravenous cannula. Remember the evanescent benzodiazepine receptors. So that intramuscular diazepam would be superior to waiting for the cannula. You can put in a cannula and your second dose can become intravenous. Yeah. The buccal, the same data is not there.
Yeah.
So buccal is not there actually.
Buccal sometimes it depends on the seizure type also.
Lots of secretions coming and like it
If there are difficulties with each of these.
Yeah.
And then the other question is, so you mentioned about this gamma internalization. So what is the place for the midazolam infusion? If the patient has not responded to previous to midazolam or to midazolam in doses which they have given. So what is the place to give IV midazolam? I know the answer, but just for.
Yeah. So again, now like we were saying, when you are managing status epilepticus, the evidence becomes shakier and shakier and shakier as you go down from the first line therapy to second line therapy to the third line therapy. So by the time you come onto the infusions, right? The anesthetic agents, the infusions we are talking about, the evidence is very shaky, right? It's a lot of things, just observational studies and things that we have seen and what you have seen and I have seen and things like that. So with that, and I think probably having managed, I think probably like Sanjay was saying, you also have seen plenty of patients and we all have seen. Although we talk about internalization, there do seem to be enough medication, enough receptors left for midazolam to be acting on, but we are talking about what we call anesthetic doses of midazolam, which we are talking about going up to 22 micrograms per kg per minute. Right? So huge doses of midazolam is what we are talking about. And we would be even looking at might be thinking of at least abolishing a non-convulsive status. But now this is like again very like a personal practice not data. Ketamine seems to be having some advantage there. Again, the NMDA receptors, right, which have come out ready for you to act on. The ease of like maybe not having to take over the other, right? So that part, and also the third advantage being not having hypotensive side effects. As you know, part of the neuroprotection, like now there are lots of changes happening with the status epilepticus, which is going to end up with reduced cerebral perfusion, and keeping up the mean arterial pressure is one important or the most important part of neuroprotection, and ketamine will help that, whereas the other agents that we have talked about, especially midazolam, would be counterproductive for that test, and you also end up putting the patient on iron drops as well to maintain your blood pressure. Just to add to that, there was a concern that ketamine was increasing intracranial pressure. I think probably all of us know that that data is no longer found to be valid.
There's one comment, I think, rather than a question from someone going to is there no cannula? Why not put one soon? Takes no time.
That's all. That's
Okay.
all. So probably I think that's a very important
Yes.
thing that we have to talk about. So something that I did not talk about. So even if you don't have intravenous cannula, as we know that the intravenous route is the most important. That's one of the things that we have to keep stressing. We'll always try to put in an intravenous cannula, failing which we might be using the intraosseous pathway, especially in the pediatric patients.
Another one question, just the last one. How long we can go for IV midazolam infusion? How long we can go for IV midazolam infusion?
Very difficult question to answer. I don't know whether anybody has a correct answer for that. I don't know, right? Again, midazolam shows this phenomenon of what we call tachyphylaxis, because the longer you use, right, the more useless it is going to become. So generally, we would be talking about 24 or 48 hours of having gained seizure control. And if at 40, definitely beyond that, if you are going to have to think of another agent. And for much earlier than that, of course, if the seizures are not getting controlled.
I think we can say that all what we are discussing is evidence-based, mainly for initial treatment of the early seizure status and also treatment of established status, where we use a second hand. Beyond that is based on the lower levels of evidence. So therefore, I think you don't say to make a recommendation, it's very difficult, but these are all indications which have their own downfalls and also have their own positives, depending on the problems that we face at that time.
Okay, so just some interesting things if anybody is interested. And so one of the things that I think that was the second reference, right? They were talking about this concept of now we are treating the mechanisms of status epilepticus is different from the mechanism of normal, like seizures, and we are trying to use the medications that we are treating for normal seizures to stop status epilepticus. And if we like switch the mode and look for something specific for status epilepticus, we might be doing better, and that's what the people are trying to do right now.
Okay, thank you.